Okay, chapter 11, the muscular system. This is probably the longest chapter that we have. The information I'm going to give you is going to be rather repetitive. We're going to go through a lot of different muscle groups. We're not going to get through all 696 of them, but we are going to get through the majority of them. I did partition this very similarly how we did the skeletal system. So I did all the axial muscles in this particular video. And also the second video, or the second part, will be all the appendicular muscles. So we'll kind of follow the same format we did with the skeletal system. So when I have the quizzes ready for you, we'll make sure one is solely for the axial muscle system, and the other one will be for the appendicular muscle system. Now, this will be a little bit different sequence of power slides, different from the one you guys have in both the lecture and the student versions. There's a little bit of intermix. If we were in class, I would actually partition them or skip through, but since it's a little bit easier for me to just do it on my own here and just separate into two separate parts, I think that'll be a lot easier on the rest of you. Okay, so basically the skeletal muscles are going to help produce motion, or they're going to basically provide a static point to allow other motion for other muscle groups. So basically the skeletal muscles are going to exert force on the tendons, and the tendons will pull bones in basically different planes of different joints, and based on the joint will basically give us a number of different muscles that allow to pull in usually an antagonistic style of motions. So usually you have one muscle that pulls it one way, you generally have another muscle that's going to pull it back in the opposite direction. So let's talk about some points of every particular muscle you're going to run into. We're going to talk about origins and insertions for every particular muscle. Most of the muscle you're going to come across will cross over a joint. Most, but not all. The majority of the muscles found in the axial and the appendicular skeleton, almost all the muscles actually in the appendicular skeleton, will be crossing over at least one joint, sometimes two in some cases. The muscles that are going to be around the face, the sphincter muscles, the areas that either will close an orifice or open an orifice, do not cross over certain joints. In fact, the only muscles that will cross over a joint in the skull and the face is going to be the jaw, or the temporomandibular joint, which has its own separate set of muscles that we'll talk about in a little bit. But very simply, when muscle contracts, you've got two endpoints of the muscle. You have an origin and you have an insertion. The origin typically is going to be closer to the midline of the body, although not always. But very simply, it's the attachment point that is going to be part of the stationary part of the bone. The most distal usually will be the insertion point, which is the area that's going to move the most when you contract the muscle, usually at the distal part of the bone. Now, in some cases, a muscle will be known as what's called a reverse muscle action. Very simply, the origin and insertion can flip-flop depending on which one stabilizes first, and I'll point those out. There's a handful of them when we get through the axial and appendicular skeleton. But all muscles have a belly. That's where all the contractile tissue will be found. The tendons, of course, will run from the bone at the insertion point to the belly of the muscle, and also from the other end of the belly of the muscle to the insertion point at the end of the bone. So other parts are going to include the belly. This is going to be the fleshy part of the muscle between the tendons. That's where all the contractile tissue will be found. We're going to identify certain muscle groups by the action, what kind of movement that the muscle will attain upon contraction. And we'll notice that a lot of muscles, depending on how things are going to be, the fibers will be laid out, and they actually have multiple actions depending on what part of the muscle will be contracting. So as mentioned before, you'll find some muscles that are going to be reverse muscle action, RMAs. Some muscles like the levator scapulae, that's going to be found attached to the cervical spine, out to the superior portion and medial portion of the scapula. Also, your iliopsoas muscle are all known to have reverse motions. And the last thing we'll talk about is innervation. It's not quite fair, but unfortunately you'll have to learn some of the nerves on the fly. We'll be talking about a lot of cranial nerves. We'll be talking a lot of spinal nerves in particular. These are somatic or motor nerves that transmit the action potential to the muscle spindles. Basically, again, the synaptic end bulb or to the motor end plate. We'll be talking about how these nerves will interact with those particular muscles and what we would expect to find if that particular connection is somehow cut or somehow diminished. Now, when we look at certain joints, basically we're going to be looking at how the muscle will interact with the joint and also how we're moving certain types of loads. So when we look at different types of loads, we use our physics knowledge to basically talk about 3 different kinds of levers. So basically there's going to be certain types of points on the lever. We'll talk about the load, which is actually the weight you're going to be moving. We're going to be looking at the fulcrum, where the axis of rotation will be found, and also the muscle will be actually doing the effort to actually move the load along the fulcrum or along the axis point of the fulcrum. And we'll see how each of those 3 components will differentiate in different positions, which gives an idea of what kind of lever we're actually talking about throughout the body. So you have 3 types of levers. You have a first-class lever, which basically has your fulcrum dead center. You have an effort on one side. You have the load on the opposite side, very similar to the handle of a scissor. So a lot of times you'll see this with a lot of opposing actions like flexion and hyperextension. You'll see left lateral flexion, right lateral flexion. So very simply, the effort is going to be pulling down in one direction, which is going to help to actually raise or almost cantilever the load in the opposite direction over the fulcrum. So you find these a lot of times along the spine, although not always in the spine. There's some areas there too. But the majority of the times you will see these, especially on the cervical, thoracic, and lumbar spinal areas. The next is the second-class lever. We'll only find one in the anatomical position, and that's going to be at the calf across the ankle. In this case, the fulcrum is going to be at the end point, and the effort and load will be on the same distal side from the fulcrum itself. So the effort is pushing up against the load that you'll see here. Now, if you notice, I said anatomical position. So if you're standing in the anatomical position and you push up or contract the gastrocnemius muscle, the calf muscle, it'll create the second lever type of action, and it'll raise the load up with the effort. You can achieve this as well in the push-up position if you're able to push up off of your onto your fingertips with lifting the palm up. But we don't see that normally in the anatomical position because you're not face first or prone in the anatomical position. So the ankle and the calf muscle are the only second-class lever that we really see in the anatomical position. The most abundant lever you're going to see is the third-class lever, where the fulcrum will be on one endpoint, and then you'll find the load and the effort again on this line, but this time the effort will be between the fulcrum and the lever. So you'll see this in a lot of the muscles up along the extremities, both in lower and upper extremities. You'll see this across the shoulder, across the elbow, across the fingers, the wrists. You'll see this across the ankle, the knees. Pretty much most of your hinge joints, you'll find this across your condyloid joints as well as the ball and socket joints in certain positions. Now, the strength of the muscle is due to what we call the fascicle arrangement. So your muscle fibers can be arranged in parallel bundles within fascicles that basically will, in relation to the tendon, actually will pull a muscle or pull the tendon in a certain direction, in a very controlled direction, to allow a very powerful style of move. So this fascicular arrangement is usually correlated with how much power the muscle can produce, the range of motion the muscle can produce as well. So if you remember from last chapter, I talked about a long muscle is a strong muscle. What we see a lot of times is the longer the fiber, the greater the range of motion. Now, the power of the muscle depends on the cross-sectional area. So naturally, we see a very high cross-section area in your bicep versus your tricep, and we do the hamstake labs when Dr. Talmont shows you the hamstakes. That's literally a cut through the upper lower extremity. If I remember correctly, I think she has one from the leg. So a lot of times what we see is the quadricep muscle has a very high cross-section area, which definitely means that it's obviously going to be a very powerful muscle, which obviously we need as humans for locomotion and also trying to keep us erect. Comparatively to the hamstrings, even though there's a decent cross-section area, you are stronger on the quadricep side. So in this case, as far as humans go, you'll see that humans are far stronger on the anterior muscles of the proximal upper and lower limbs. Whereas if you look at a quadruped, you'll see just the opposite. A lot of times you'll see the triceps will be far bigger on, say, like a cat or even a pig versus the bicep. And also you'll see the same thing happening with the lower legs, although you see in pigs, so you look at hamstakes, the quadriceps tend to be far stronger than hamstrings because the pigs very simply don't run very fast. You see in some animals that run very quickly, in particular most of your carnivores or even horses, you'll notice that the quadriceps and the hamstrings have a little bit more of a balance point. So we see arrangement of fascicles in a lot of different types of orientations. You see a lot of muscles that are going to be the parallel form, where very simply you'll see that the actual belly of the muscle is roughly uniform to the tendons themselves. If they tend to get a little swollen, that's what we call fusiform. So you see this a lot of times in some muscles like the digastric muscle. You may see this in the biceps or one particular head of the bicep. Occasionally, if you see a muscle that's going to be either opening or closing an orifice or opening and closing a sphincter, they'll have a circular orientation through here. So a lot of times you'll either contract the muscle and it will expand, or contract the muscle and actually tighten over a certain particular spot. Occasionally you'll see a triangular type of orientation. You see this with the pectoralis major, the major muscle of the chest, where it's a very strong muscle in a lot of different directions, comes to a very strong point at a very strong tendon in particular. Occasionally you'll see different muscles that will be almost like a leaf-like type of orientation we call pennant, and we see them in three different types. You see unipennant, where very simply you see a little more of a swollen orientation to one side. You'll see bipennant. You see this a lot of times in the rectus femoris muscle, which is going to be found in the quadriceps, where there's a very strong central tendon, and then you see it flaring almost like two portions of a leaf, bipennant. And very rarely you'll see a multipennant, in particular in this case the deltoid muscle, which we find in the shoulder. So you see the fascicle arrangement of cells along several different tendons, so basically to achieve different direction. The deltoid is somewhat unique because you have a combination of abduction, you've got a combination of a little bit of extension as well as a little bit of flexion depending on how much of the muscle is being contracted. Now occasionally you'll see muscles that will coordinate with other muscle groups. So the way we differentiate these is very simply, you'll have opposing pairs, which will be an agonist and antagonistic setup, where, say for example, if we're working on the elbow, bicep tricep is a great example. So if I'm looking to flex my elbow, the agonist muscle is going to be your bicep. The antagonist muscle will be the tricep. So when we look at agonist and antagonistic groups, especially when we look at reflexes later on into the nervous system chapters, we're going to see a lot of times the brain does a cool trick with reciprocal inhibition. So if I want to get a strong contraction on my bicep, the brain will shut down the tricep to allow full contraction on the bicep as best possible, without looking into fatigue and energy storage and so forth. And then basically the antagonistic muscle, once that the agonist muscle actually relaxes, then the antagonistic muscle a lot of times will contract to allow a very smooth transition going back into the extension or sometimes the hyperextension pose for the elbow. Occasionally you also have certain muscle groups that will be synergists, that will kind of aid the agonist or stabilize intermediates. So you see this a lot of times in thigh muscles. So if you look at a runner in particular, so to make sure that they're running in somewhat of an efficient position, basically as you go to land, yes, your quadriceps and hamstrings help guide the motion, but your IT band, your tensor fasciae lata, your adductor muscles help prevent or help lock the hip and the knee in place to allow the proper load transference and allow you to push off properly without putting too much damage on the hip. You have fixers. These will provide a stable base to perform an action. The best example I can give you is the rotator cuff muscles, which we see a lot of problems with in practice, where a lot of times if your stable base, in this case the scapula, is not in the right spot, basically all the muscles of the upper arm, especially if you're doing any kind of motion where you're looking to pick something up, or if you're typing or you're throwing a ball, if those fixers are not working properly, it puts a lot more of the muscles in a very precarious situation, and you're prone to tearing, you're prone to inflammation, and a lot of different issues there, bursitis, you name it. Now, the muscles can be named in a variety of different ways. They can be named as far as location, like pectoralis, which we know is obviously in the upper chest area. The size, all the adductor muscles, you'll find them named by the magnus, they'll name by the brevis. So we go by the size of certain things. Occasionally, the number of origins. So in this case, the quadricep muscle. There's be different types of points there. The appearance, like the serratus anterior muscle, serratus meaning very saw-like, direction of the fibers. If we look at like longitudinous muscles or longissimus dorsi, gives you an idea of the direction the fiber is going to go. The origin of insertion, levator scapulae, tells you inserts into the scapula. The intertransverse right muscles will tell you that they attach in between the transverse processes of the vertebra, or simply will tell you by the muscle action. So if you look at, again, like the adductors of the hip, they'll basically tell you that it does adduction, as you surmise. So a lot of skeletal muscles, for the most part, tend to at least give you a clue to either what they do, or where they're located at, or what their appearance looks like. So at least the name does help you out a little bit. So this chart here, very simply, we'll go into a couple of the more well-known ones. Your abdominal muscles are great for the actual direction and orientation of the fascicles. So your rectus abdominis will run parallel to the midline. You got transverse also will go perpendicular to that midline, and the obliques will go diagonally. We look at size, and one of these things that, if you remember before, when we were talking about anatomical landmarks and look for directions, if you have a superior, you're pretty well sure you're going to have an inferior. If you're going to have a lateral, you're more reasonably sure you have a medial too. Same thing with the muscles. So if you're going to have a maximus, odds are there's going to be a minimus, sometimes a medius if there's going to be an intermediate. So in this case, the gluteus max, you have gluteus minimus, and you actually do have gluteus medius, which is very important for the walking gait. If you have a longus, you have a brevis. You see this a lot in particular with the wrists. You see this a lot in particular with the ankles too, with all its muscles that will traverse into the wrist, the hands, the fingers, and I'll see that with all the ankle and also the foot. The latissimus muscle is very wide. Longissimus muscle will be very long. Longissimus muscles, you'll find those along the spine, like the latissimus capitis. Capitis, as you would kind of ascertain, is more so for the head. Magnus, major, minor. Vastus means just a very large muscle. The vastus lateralis muscle is one of the very large muscles that makes up the quadricep. And occasionally you'll get certain muscle groups that will be named by the shape. So deltoid triangular, and I won't go through all of these, but go through a couple of them. The rhomboid muscle is diamond shaped, and I'll show you what that looks like when we get into the thoracic spine and the scapula. Brachiosaurus is going to be circular. The quadratus muscle is more square-like. So you kind of get the idea of what we're looking at through there. So occasionally the muscles will be named also by what kind of action they do. So the flexors and extensors, again, opposing or antagonistic muscle groups. You'll see these a lot of times in also the hands and also the feet. You have flexors and extensors, the abductors, adductors. You'll find these in particular within the fingers. You find this within the hip. Levator, as you would again kind of ascertain, it helps elevate a certain body part. So if you have a levator, you have a depressor. Supinators and pronators, we'll look at these especially in the arm. The sphincters, as we see, will decrease the size of an opening. Occasionally, though, like the internal sphincters will actually open up an area. Tensor fasciae lata makes a part more rigid to stabilize certain things, and rotator cordis will rotate. So occasionally you'll notice that number of tendons as well, or number of origins, will also dictate the name of the muscle. So the biceps would, as you would think, would have 2 origins or 2 heads. Triceps, of course, have 3. Quadriceps would have 4. But occasionally you might find, especially the muscles around the face, that may tell you what the location is. So in this case, the temporalis bone, it basically will originate up around the temporal bone and then insert into the jaw. And occasionally, if you're lucky, you'll get a muscle like what's called the sternocleidomastoid. It tells you in the name where it attaches to. So in this case, it goes from the sternum down to up to the mastoid process, just off the occipital bone. All right, so when we do the quizzes will entail any one of these slides you can see here. They're going to be most of the superficial muscles, and when we get down deeper into the spinal areas, I'll give you an idea of how deep we're going to go as far as trying to identify certain muscle groups, but this is fair game. So these are all the anterior muscles, and we'll go through these a little more thoroughly. So again, when we do the quiz, however, when we do axial skeleton, I'm not going to throw up this slide and ask you to find me the bicep. We're asking you to find the quadriceps, because that's going to be more so for appendicular. But I will use a slide like this for each individual quiz for both the axial and also the appendicular muscle systems. But these are a very good way to kind of orient yourself. I will say this, you will see this on your exam. So I would definitely study this inside and out, especially these muscles. This is not the exhaustive list. There's more muscles they're going to identify. But this is one of the main slides I want you to kind of pay attention to. And of course, if we have an anterior, we're going to have a posterior. So again, this one I find to be a little bit easier, because especially with the upper and lower back muscles, a little easier to see. But unfortunately, you do have to be very careful when you start identifying muscles of the forearm, And I'll be fair, I'll try and use like some of the better slides that kind of really kind of zoom in on those particular muscle groups. And I'll try and pinpoint how you differentiate one from the other as far as the wrist muscles go and how to differentiate the quadriceps and so on and so forth. But again, this slide is also fair game. Now, this is not in your text. I threw this up here mainly because I want you to at least get an idea, because unfortunately when we talk about the individual muscles, there's 5 things to the muscle that you need to know. One is obviously the name, and again, spelling is important, but it's not going to make or break it, especially when you do the quiz and or when you do the exam. But you're going to need to know in general what the origin insertion will be, and in general know where you're going to find those. So I'm not going to get too nitpicky with that, but the last 2 that I'm going to be really nitpicky on is going to be the innervation, where I need to know what nerves are going to control those particular muscles. So this nerve map will help you a little bit, and I'll show you some tricks depending on what kind of muscle groups that we're talking about, especially when we get into the appendicular muscle system. And of course, the last thing is going to be the action. I definitely want you to know the actions of all the particular muscles and all the different actions. If a muscle has more than one action, you got to know them all. Like I said before, for the most part, some of the muscles will definitely have at least give you a clue based on where they are, or the name of the muscle will give you an idea what kind of actions they do. So again, 5 aspects for every muscle: name, origin, insertion, innervation, action. Innervation and action, besides the actual name of the muscle, are probably the most thing I'm really going to kind of focus on more than anything else. The origin insertion, if I give you a question on the exam, it's going to be readily apparent. If you know where the muscle is, you should know where the general origin insertion is going to be. Okay, so this one's just a very quick overview. I'll let you guys go through this yourself. It's not animated. It's one of those things where you click on a muscle, it'll show you the muscle, and it'll list very simply the origin insertion, the action, innervation. Okay, so we're going to try and break this up as best I can. We'll start off first with the muscles of head and facial expression. So for the most part, what I try and do, if we're going to do any kind of quiz on these particular slides, usually the ones that are going to be in boldface give us the best picture of those particular muscles. So I want you to basically pay attention to those particular points, anatomical points, when we go through these individual slide here. So in general, you'll probably see about 1 or 2 slides, then it'll actually show the chart. That'll tell you the name of the muscle, origin, insertion, innervation, as well as the action. When we get into the muscles of head and facial expression, there really is only one nerve that really controls most of these. It's a cranial nerve called the facial nerve. So that's something to kind of remember. The facial nerve will control most of the muscles of the face. So against cranial nerve 7, which we'll go into more in depth and get into brain and cranial nerves. But again, you at least have to know what the name of that nerve will be for most of the facial expressions. Now I just want to point out a couple different muscles through here. I don't want to go through them all, but I'll go through a couple of them here. So basically what you're looking at are going to be a couple very important muscles of the face. The orbicularis oculi will naturally help close the eye. If you look at some of the names of these muscles, levator labii superioris. So if you look at the levator, it means it would raise up. Labii means lip. Superioris means that it's basically above it. You're also going to have the depressor labii inferioris. So that's going to be the opposing muscle. That's going to be one that depresses or pulls the lip downward. You're going to see some other special muscles like the platysma. That's going to help basically pull the head into a flexion position, also to help depress the chin. You got the risorius muscle, which is very important because it helps in particular with drawing your face down to a grimace. Other special muscles will be the zygomaticus minor and major. This helps you smile. If you look at the angle of where those muscles are, helps draw the lips up into a smile position. If you have the orbicularis oculi for the eye, you've got the orbicularis oris for the mouth. Oris meaning oral. You can try and remember that. You have the buccinator muscle, very important for whistling, and very important especially for babies in particular. If you're sucking on a baby bottle, as we get older, we suck on a straw. It's a very important muscle. If you start to lose any kind of innervation on the buccinator muscle, it creates a lot of havoc with using any kind of mouth function. One other thing I want to point out to you as well is the masseter muscle. It's a very strong muscle, but it's for the jaw. It's going to be a little bit separate than the rest of the muscles of the head and facial expression. You only really see it when someone grits their teeth, but it's more so for jaw motion, which I'll get to a little bit later on. And last one I show you is the mentalis muscle, found in the mental area just at the center point of the chin. The mentalis muscle is your pouting muscle. This one helps draws the lips down a bit. So mentalis can be for pouting, risorius muscle for grimacing, and the buccinator muscle for sucking and also for whistling. The zygomaticus major and minor muscles are going to be good for smiling. Okay, so here is a lateral shot of muscles of the head and facial expression here. So this is a nice shot if you look at the overarching view of the occipital frontalis muscle from both the frontal belly as it wraps around over top of the head to the occipital belly. So this is going to be knitted together by the epicranial aponeurosis. So a lot of times you see this muscle get contracted when you see a lot of patients, in particular in my office, that sit for a long period of time. They do a lot of computer work, which unfortunately most of us are doing right now. This causes a lot of headaches, causes a lot of tension headaches in particular. So it's a great shot from the side here. Now, I will note two muscles that work with the jaw. One's going to be the temporalis muscle, real thick broadband type muscle there, which helps elevate the jaw. The masseter muscle, like I mentioned before, is a real strong, thick muscle, which compared to other primates, we have some of the weakest masseter muscles out there. Gorillas have really thick masseter muscles, and also some monkeys as well. But still, those help kind of mash the teeth together, help elevate the jaw, and help aid in grinding a little bit there as well. But you can also see a nice little shot of the zygomaticus major as it draws upward on the lip with help with smiling. You have a nice shot of the buccinator muscle as well as the risorius. So again, if you can orient yourself a little bit through there, you can kind of tell why the buccinator helps pucker the lips for whistling and also for sucking on a straw, and also where the risorius muscle help pull the lips outward and down, almost in a grimace, so to speak. One little thing I'll show you here too, if you look at the platysma is a very flat, broadband style of muscle that, again, will help kind of depress the jaw, depress the mandible, and a lot of times will draw the head a little further downward. Okay, here's a nice little chart of everything that we talked about here. So again, the main thing I want you to be aware of is simply the name of the muscle, have a general idea of the origin and insertion. I definitely want to know the action of each particular muscle. And thankfully, most of the muscles on this chart, if you notice on the far right-hand side there, they're all innervated by the facial nerve, cranial nerve 7. So if you got to guess, if you're not sure what kind of nerve will innervate the muscles of facial expression, going to say the facial nerve. Now, there's other ones. There are other cranial nerves that will basically work with other muscles in and around the skull, but I'll kind of point those out to you as best I can. But again, facial nerve is your go-to nerve for any kind of muscle or face expression. Okay, here's the remaining muscles that are part of the head and facial expression. So my mistake. The platysma will help draw the lower lip inferiorly and posteriorly, as in pouting. This also will aid in the pouting motion. The corrugator supercilii, which I mentioned before, helps wrinkle your eyebrow. It's going to be at an angle. It's going to be at the medial end of the archfrontal bone up the skin of the eyebrow, so it draws the two eyebrows together towards midline. But again, also will be innervated by cranial nerve 7, facial nerve. So your first question. So now that we know the muscles that basically control most of the different actions of the face, and also we know that the facial nerve controls all those muscles, let's do a hypothetical. So in this case, you're an attorney. During a facelift, the cosmetic surgeon accidentally severs the facial nerve on the right side of the face. So what are some of the effects this would have on the patient, and what muscles are involved? So basically you think of pretty much any kind of facial expression. That could be smiling, could be grimacing, could be blowing, whistling, it could be frowning, it could be pouting. Any number of things could have been affected by having the facial nerve severed. So basically, if you were to answer any one of those muscle groups or any one of those particular actions that could be affected, you'd be correct. Now, let's talk about some other issues with cranial nerve number 7. So I actually have a handful of patients that have had Bell's palsy. I have one patient that had a severed nerve for something very similar to this, but what happened was she actually got into an accident and her face parts went through the windshield, so cut a portion of her facial nerve. So unfortunately, she wasn't able to basically raise her cheekbone on the one side. But do you ever know patients that have what's called Bell's palsy, where it's basically what we call facial paralysis, where very simply, if the cranial nerve 7 is inflamed, or let's say it's being attacked by some kind of infection, In this case, a lot of times by herpes simplex. Then a lot of times the nerve conduction just is not, it's not capable of conducting any kind of nerve impulse. So a lot of times you have either just inflammation, which causes sometimes a very temporary type of paralysis, or actually will cause full-blown nerve damage. Occasionally, though, I mean, the recovery is good for most of these patients. 80% can get some of their motion back, but unfortunately, there is a few, small segment of that particular population where it's permanent. So in this case, you can see from the person, our person here is facing us. The left side is fine. The right side looks like it's completely relaxed. So in her case, she can't wrinkle her brow. She can't open or close the eye. So a lot of times, these people will wind up having a lot of eye drops to keep the eyes moist and they'll dry up. She can't puff her cheeks. She has no muscle tone. So we talked last chapter about a flaccid versus a spastic muscle. In this case, the muscle, if they're not innervated for a long period of time, they'll almost feel like mush, almost like like a pudding type of consistency, to some extent. Some of these patients also tend to drool a little bit, especially if that corner mouth really drops down low. So a lot of times they're constantly wiping their mouth. Okay, so muscles for eye movement and also the eyelids. So there are 6 muscles that move the eye. 4 of the muscles are named as rectus muscles, so thankfully they're in pairs. You have a superior and inferior rectus, you have a medial and a lateral rectus. So they basically, if they says superior rectus, it pulls the eye upwards, so it looks in the superior direction. Medial will pull it medially, lateral will pull it laterally, inferior will pull it inferiorly. Now you also have 2 other muscles. They're going to be your oblique muscles. You have the inferior and superior obliques. So if you notice first, look at the inferior oblique where it attaches to. It's going to attach just at the inferior medial portion of the eye socket, just along the zygomatic bone. So what happens is when that muscle contracts, it's going to pull the eye from a medial to lateral portion up towards the superior range. Okay. Now, if you look at the superior oblique is a little bit different. If you notice, it's going to hook around the trochlea. And if you guys remember, in the elbow you had a trochlea too. There's a second trochlea. It's almost like a little hole there, where it's going to be formed by a little ligament there, where the superior oblique is going to hook into that particular spot. So when that muscle contracts, it's going to pull the eye also from medial to lateral, but it's going to go through the inferior arc. So it's going to go opposite what you normally think. The superior oblique is going to pull you through the inferior arc from medial to lateral. The inferior oblique muscle is going to pull you through the superior arc, the superior arc from medial to lateral. Okay, so again, there's a nice little chart here to give you a good idea of which muscle does which particular action. So you can see the superior oblique is going to bring it from the inferior arc, the inferior oblique is going to bring it from the superior arc, from the medial to lateral, and of course you have the 4 rectus muscles, superior, inferior, and medial and lateral. So the eyes are going to be used in conjunction. So if you're looking up and down, superior and inferior, then both superior rectus muscles on both sides, both inferior rectus muscles on both sides will be used simultaneously. However, the medial and lateral rectus muscles, if you have both eyes going to the left, you have your left rectus and your right medius contracting at the same time, and vice versa. If you're pointing your eyes to the right, on the left eye you have the medial rectus contracting, on the right you have the lateral rectus contracting. Now, there's a little mnemonic that we use for the innervation for the muscles of eye motion. What you want to think of is SO4-LR6. SO4-LR6. So basically you have 3 nerves that control the majority of the muscles. If you remember SO4, SO is superior oblique muscle. Okay, it's going to be controlled by the 4th cranial nerve, which is known as the trochlear nerve. Remember, it had a little hook there for the trochlea, for the muscle the tendon is going to be knitted through. So SO4, superior oblique 4, trochlear nerve. LR6, your lateral rectus, is going to be controlled by the abducens nerve, cranial nerve number 6. The other 4 muscles, superior rectus, inferior rectus, medial rectus, inferior oblique, are all controlled by cranial nerve number 3, the ocular motor nerve. So if you remember, just those other 2 are special, SO4, LR6, you should be able to remember what the other innervations are for the other 4 muscles. So you have 3 nerves in particular: ocular motor number 3, trochlear nerve number 4, abducens nerve number 6. 3 cranial nerves to cover all different motions of the eyes, And the last one we'll talk about is the one that actually helps raise the eyelids, is the levator palpebrae superioris. That's going to be controlled also by the ocular nerve number 3. Okay. Mastication and speech. So mastication very simply means chewing. So way back when I was in school, this is before they changed some of the muscle names around a little bit, we used a mnemonic called time. So this basically named the 4 muscles, and there's 4 muscles that are going to aid in mastication or chewing. You have the temporalis muscle, which is the large broad-banded muscle that you see just on the lateral side of the skull by the temporalis bone. You have the masseter muscle, which is cut away here. So that's going to be the T and the M out of your time. Now, back when we were in school, we had the internal and the external pterygoids. Now they renamed them to medial and lateral. So you think internal, medial, lateral will be external. It's a nice, easy way to remember it. If you want to come with a different mnemonic, that's fine too. But what happens is your temporalis muscle is going to help elevate the jaw. The masseter muscle is going to help with the actual strong compression of the jaw. And then your lateral and medial pterygoids, if you basically will grind your teeth left to right, right to left. So what happens is your lateral medial pterygoids will form almost like an X pattern, so to speak, on either side of your jaw. So if you're going to swing your jaw to the left, then your left lateral pterygoid and the medial right pterygoid will contract on one side and then vice versa. So if you swing your jaw to the right, now your lateral pterygoid on the right side is contracted, and now your medial pterygoid on the left side is contracted there too. Helps grind away your food. Okay, so the other important muscle group for mastication is going to include the muscles of the tongue. Also helps form different orientations in the mouth for speech. So we're going to look at 4 muscles in particular here. You know, there's 5 highlighted. There's 4 muscles in particular that are going to help guide the tongue. We're going to start with the genioglossus muscle. So anytime you see glossus, that means tongue. And it's also going to be controlled by what's called the hypoglossal nerve, which is going to be cranial nerve number 12. So now your genioglossus, if you notice, that's going to be just anterior inferior to the tongue. So it's going to pull the tongue anteriorly, almost like a protraction when you stick your tongue out, and also going to pull it a little bit inferiorly there as well. If you continue over to the hyoglossus muscle, found just inferior to that and posterior to that, you can see where it's oriented, where the fibers are. That's going to pull the tongue back and also depress it there at the same time. If you look at the styoglossus and the palaglossus muscles, the styoglossus muscle, since it's going to be more posterior, will pull the tongue back there as well. Where your palaglossus muscle is more so almost just a bit superior to the tongue itself, will help elevate the tongue and put it towards the roof of the mouth. All of the muscles there, again, as I mentioned before, are going to be controlled by the hypoglossal nerve, with the exception of the palaglossus muscle. That one, unfortunately, just strict memorization. That one is going to be innervated by the vagus nerve or cranial nerve number 10 and a portion of the pharyngeal plexus. So let's go back real quick and look at the time muscles in particular. All 4 of these muscles that control the jaw itself, okay, are going to be innervated by the mandibular division of trigeminal nerve, cranial nerve number 5. So the best way to remember this is your trigeminal nerve has 3 partitions to it. In this case right now, you're talking about the mandibular division of the trigeminal nerve. So it's going to be the masseter, the temporalis muscle. They're going to help elevate the mandible and close in the mouth. The temporalis also will retract the muscle, so it actually bring it back towards the posterior bit ever so slightly. Not much, but ever so slightly there. They have the medial and lateral pterygoids. It's going to help elevate and protract the jaw and also move the mandible from side to side as in grinding. And again, there are your 4 glossus muscles. There's a genioglossus muscle that's going to be found underneath the tongue. It's going to depress the tongue and push it anteriorly. Styoglossus is going to be found just behind it. It's going to help draw posterior and also elevate it slightly. Your hyoglossus muscle can help depress the tongue and draw it down on both sides. And of course the palaglossus muscle. The only one that's going to be the oddball out of those 4 muscles that's not innervated by hypoglossal nerve is going to be innervated by the vagus nerve, cranial nerve number 10, and also the pharyngeal plexus. It's going to elevate the posterior portion of the tongue and also draw the soft palate down upon the tongue. Okay, here we're going to be looking at the anterior neck. So these are what's called the deglutition muscles, also help aid in speech. So deglutition is going to be the act of swallowing. So we partition these to both the superior or suprahyoid muscles and the infra or infrahyoid muscles by virtue of looking at the hyoid bone itself. So all the muscles that are going to attach from the superior into the hyoid bone are going to be the suprahyoid. Everything that's going to be just inferior to that will be the infrahyoid. And we're going to look at roughly 4 muscles on either side here. So the one that is not shown on this particular one because it's been cut away is going to be the genohyoid muscle, which you saw a couple slides back. It's going to be just anterior to the mandible. It's going to attach basically from the hyoid bone at the insertion point to the inner surface of the mandible. So each one of these muscles is going to help elevate the hyoid bone to basically allow food to drop down through the esophagus. Will also help aid in speech a little bit there as well, but for the most part helps elevate the hyoid muscle, elevate the hyoid bone. Excuse me. That's going to include the digastric muscle. It's going to include the stylohyoid, the mylohyoid, and also the genohyoid, which I mentioned before, is not shown on this particular slide. Now the innervation gets a little bit tricky on this one, so I probably won't test you guys very much on this one, but it's just helpful to know. So basically the digastric muscle, because you're going to have 2 separate bellies here, you have both an anterior and posterior belly, you're basically going to have different innervations here. So this is going to be the one that transitions between, let's say, the jaw and also the facial muscles. So the anterior belly is going to be innervated by the trigeminal nerve, the mandibular division. The posterior belly is going to be innervated by the facial nerve. The stylohyoid muscle, which is going to be found just actually in between the 2 bellies of the digastric, will also be innervated by the facial nerve. The mylohyoid muscle is going to be just a little bit superior to that, a little more broad. That's also going to be innervated by the trigeminal nerve as well. If you think it's very close to the jaw, just think of the trigeminal nerve, the mandibular portion. The genohyoid muscle, because it comes down a little bit further, a little more anterior, a little more inferior through the hyoid bone, this is where we start getting into branches of the spinal nerves. So we name the spinal nerves by which vertebra they protrude from. So in this case, it's going to be the first cervical spinal nerve. So it's going to be between basically occiput and C1. Now we look at the infrahyoid muscles. These will help depress the hyoid bone. So you've got the omohyoid bone as well as the sternohyoid. You have the sternothyroid, and just note there's going to be 2 different types here. So the sternohyoid is going to attach from the sternum to the hyoid. The sternothyroid muscle is going to attach from the sternum to the thyroid cartilage. So it's a very distinct differentiation, but they actually do the same motion. They all help depress the hyoid bone, although the sternothyroid bone also helps depress the thyroid cartilage or the larynx, very important for speech. The last one out of the 4 is going to be the thyrohyoid. That's going to help depress the hyoid bone, but also this is going to be one of those reverse muscle action muscles. So again, something to kind of pay attention to. It's going to help elevate the thyroid cartilage. Again, very important for speech. These will all be innervated by branches of C1 to C2 of the spinal nerves. Okay, so here's a quick breakdown of what I just talked about through there. So again, there are your 4 muscles for the suprahyoid area, the digastric having 2 bellies. The important thing to remember for this one here, you have the anterior portion and the posterior portion. Anterior is part of the trigeminal nerve innervation, posterior is part of the facial nerve. As I forgot to mention, the digastric muscle also is a reverse muscle action. So it either elevates the hyoid bone or will depress the mandible. So in other words, it depends on which one locks down first. If the hyoid bone is going to be stabilized by the other 3 bones, the stylohyoid, mylohyoid, and genohyoid, then the digastric muscle can aid in opening the mouth by depressing the mandible. If the hyoid bone is not being stabilized, basically it will help move or elevate the hyoid bone in particular, so that's going to be the first action. But once that hyoid bone is going to be established as a static position, the reverse muscle action is going to be opening the mouth by depressing the mandible. The infrahyoid muscles, as I mentioned before, just pay attention to where they attach to. They all will depress the hyoid bone, including the omohyoid and sternohyoid bone. Sternothyroid will help depress thyroid cartilage of the larynx, and the thyrohyoid is going to either depress the hyoid bone or help elevate the thyroid cartilage. The infrahyoid muscles, in particular the sternothyroid and thyrohyoid, very important for speech. Okay. This is where we get into more of my forte, this kind of thing that I deal with it day in, day out. The majority of the muscles you're going to find of the neck, if they work bilaterally, they will usually work, especially on the posterior portion, will help aid in hyperextension of either the head or the cervical spine, and in some cases the upper thoracic spine. If the muscle is acting from a unilateral perspective, they will do one of two things, and sometimes both. They will laterally flex to that side, or they'll rotate to that side. And there can be a couple quick exceptions here and there. A couple muscle groups that we'll look at in particular, the longissimus capitis. What's nice about the spinal muscles is they kind of give you an idea of where the muscles will run from and what they attach to. You see capitis, you think head. So the longissimus muscle, you notice, will actually run along the side of the cervical spine, will attach to the mastoid process. You look at other muscles, including the splenius capitis and the spinalis capitis. The spinalis capitis has the unique feature where, from an evolutionary standpoint, the spinalis capitis muscles kind of getting phased out. It's actually more so fused with the semispinalis capitis. So you don't find a separate spinalis capitis on a lot of individuals, and you really can't tell unless unless you're cut open for surgery, or if you pass and you do an autopsy, they can see whether you really have one or not. But the spinalis capitis and the semispinalis capitis for a lot of people is simply fused into one muscle, the semispinalis capitis. But for the most part, each of the muscles I just talked about, if they're working bilaterally, they work into extension. If they go unilaterally, they'll do lateral flexion and possibly both, doing the rotation to that side at the same time. Okay, so this is a nice lateral shot for the muscles of the neck. In particular, shows us two very important muscles. One is going to be the trapezius. They can see most posterior there. It's a very long, very broad muscle that's going to span the entire cervical spine all the way out to the lateral portions of the humerus and the clavicle, as well as inferiorly down to T12 in the thoracic spine. That muscle, in conjunction with what's called the sternocleidomastoid muscle, is a very strong muscle that attaches from your sternum out to the mastoid process of the occipital bone. These two muscles are going to be innervated by cranial nerve 11, called the accessory nerve. And what this does for us, it forms two very distinct triangles throughout the neck, which is very important if you're going into any kind of health field, because there's a lot of different structures that we tend to look at for any kind of issues with problems with numbness or tingling down the arms, any kind of lightheadedness, and so on and so forth. But if you notice here, the sternocleidomastoid helps form two types of triangles. You have the anterior triangle and the posterior triangle. The anterior triangle in particular is going to house a lot of different structures there. You're going to find different types of salivary glands. You're going to have deep lymph nodes found in the anterior chain. So when you go to the doctor's office and they palpate your neck and you feel soreness, a lot of times they're checking for the anterior cervical lymph node chain. But other important things there too, you're going to find the carotid arteries, you're going to find the jugular vein, you're going to find a lot of different nerves down there too, including glossopharyngeal, cranial nerve 9, the vagus nerve, cranial nerve number 10, also known as the wandering nerve, spinal accessory nerve number 11, also the hypoglossal nerve number 12. In the posterior area, the posterior triangle, looking for the posterior cervical lymph node chain, also different areas of the brachial plexus, which we'll get into probably quite ad nauseum for you guys. But that's the major nerve network. It's almost like a spaghetti-like network of spinal nerves that turns into a mesh of a plexus that innervates the entire upper extremity. So we look at this from a clinical standpoint, because if you have any kind of spasticity in either the sternocleidomastoid or shortened to the SCM or the trapezius or both, then it can definitely impinge upon all the structures we just talked about in the anterior and posterior triangle. For a full list, looking at your textbook, I believe it's to page 350 or 351, we'll give you a quick rundown of both the anterior and posterior triangle. But what I want you to know in particular is the SCM will partition both of those triangles. So again, we see the sternocleidomastoid. So the sternocleidomastoid is a very unique muscle because what winds up happening is if you have a muscle on the left, the sternocleidomastoid, when it contracts, it pulls the head to the opposite side. So it rotates the head, contracting on the left side, rotates the head to the right. Because what happens is the sternal area is the actual origin. It's going to pull in the mastoid process, so it's going to pull it forward and then across midline of the body, so it's going to pull the head to the opposing side. So again, sternocleidomastoid contracts on the left side, pulls the head to the right if it's contracting unilaterally. If both of the SCM muscles are contracting together, it's going to basically flex the cervical spine and also flex the head at the same time as well. Now, the sternocleidomastoid in certain cases is known as reverse muscle action. So if you have forced inhalation, like really trying to get real deep breath in, it helps elevate the sternum at the same time. Now, the sternocleidomastoid is also very important for those of you who are going to get into obstetrics and gynecology and get into perinatology as well. There is a condition called wry neck, where some children, when they come out of really rough pregnancy, really rough delivery, that muscle goes in spasm very quickly. So what ends up happening is when the baby comes out, you'll see a very big bulge on the side of the neck, and the head will actually turn away, down and away from that particular muscle. I've treated a couple of babies with that particular type of problem. Sometimes it goes away in a couple of days, but occasionally I need to do some very light massage on the SCM muscle to try and get it to relax and trying to calm down a little bit. You do see this in adults sometimes too. It can be painful. A lot of times you do see this with people that have any type of scoliosis, where you see this also people that are in car accidents, where, as I mentioned before, the SCM is a very strong muscle, and once it contracts, it's very tough for it to let go. It does take quite a bit of treatment to get that loosened up. Now, as mentioned before, there are some easy things with the muscles of the neck and also the spine. In this case, because we're dealing with the capitis muscles, I don't care if it's the semispinalis, spinous capitis, longissimus, or the spinalis muscles. What winds up happening is they're all innervated by cervical spinal nerves. Just simply remember that they're innervated by cervical nerves, and you'll be good to go. Okay, so let's talk about the abdominal muscles. So there's basically four major muscles for the abdomen that we're going to talk about. You're going to look at the rectus abdominis, which is going to run pretty much parallel to the sagittal plane. You're going to have the muscle called the transversus abdominis, which is going to run perpendicular to that. So the rectus abdominis will run parallel to the midline of the body. The transversus abdominis will run through the transverse plane, so perpendicular to the midline. You'll also have the oblique muscles, which are going to be the internal and external obliques. All these sets of muscles basically will help flex the thorax forward in a forward hunch position. Also help will elevate the pelvis. For the most part, though, they also aid in defecation, urination, and trying to provide intrathecal pressure to basically push certain things to the anus or through for urination. But for the most part, the rectus abdominis is more of a postural muscle. The transverse abdominis will help aid in that particular motion. The internal and external obliques will help with rotation of the trunk and also rotation of the thoracic spine. But for the most part, they also will help kind of engage the core and protect other parts of the mid and lower back. Now, what's interesting for most of us, if you notice, especially the rectus abdominis, you see the partitions there. The funny thing is most of us have that six-pack. It's just that some of us have a little more fleshy and fat in front of them. For most of them, they are relatively defined, but we see in a lot of patients in particular now, especially people that sit for long periods of time, we start noticing that the rectus abdominis gets weak over time because there's another muscle group that kind of takes over, in this case the psoas or iliopsoas muscles. So that's why we usually caution a lot of patients if they have any kind of low back issues, any kind of upper back issues, we usually do recommend some kind of core strengthening. In this case, a lot of times we'll ask them to do some kind of plank maneuver, so it's like a static position, you can hold things together. Next, let's look at the innervation for all different muscle groups here. So, very similar to when we deal with the posterior neck muscles. Thankfully, the majority of the abdominal muscles are going to be controlled by thoracic spinal nerves. In this case, the second half of the thoracic spinal nerves, so the last six. So spinal nerves from T7 down to T12. Pay attention particularly though to rectus abdominis. It's going to originate down by the pubic crest and the pubic symphysis, so it's going to actually originate inferiorly and insert up by the cartilage of ribs 5 through 7 in the xiphoid process. So this is also technically reverse muscle action. So once you flex the vertebral column, it also helps aid in flexing the pelvis, in particular along the intervertebral column at the same time. Now, as I mentioned before, there's a fifth muscle here. They're very broad, they're very flat, called the quadratus lumborum. It's a very square-like muscle that you can find on either side of the lumbar spine. You'll find these will attach from the iliac crest and the iliolumbar ligament, which is going to be around L5, right to the inferior borders of ribs 12 and the rest of the lumbar vertebra from L1 to L4. These also help stabilize the pelvis. When acting singly, they'll laterally flex you to the one side. When acting together, helps elevate the hip bone, but also helps with deep inhalation too, Quadratus lumborum is the oddball of the group. It is actually innervated by more so by the thoracic spinal nerve 12, also lumbar spinal nerves L1 to 3, sometimes L1 to 4. It does kind of change a little bit here and there. But for the most part, if you just tell me very simply that any one of the abdominal muscles are innervated by thoracic spinal nerves, especially anywhere from T7 to T12, you're good to go. So let's talk about the muscles of breathing. So these are thoracic muscles. So the main muscle group we're going to talk about is going to be the diaphragm. The diaphragm is going to be controlled by the phrenic nerve, spelled out P-H-R-E-N-I-C, the phrenic nerve. So basically it's a very flat muscle. When the muscle contracts, it actually flattens in the inferior position. It's going to create a negative pressure in the lung area. It's going to allow you to draw breath in through the nostrils and through the mouth down through the larynx. When it relaxes, it actually will balloon back upward, helps kind of push the air back out through the lungs. You have some muscles that are going to be along for the ride. In this case, these muscles are going to be attached between your ribs, so they're going to be called intercostals. You have external, you have internal. There's a very easy way to remember these. The external intercostals will actually help you pull the rib cage down and help you exhale. So external intercostals, exhale. Internal intercostals will help you elevate the ribs and hopefully open up the rib cage. Those would be for inhalation. So if you're doing forced exhalation, you're trying to breathe out, the diaphragm relaxes, the external intercostals will actually contract, and sometimes your pecs as well as the SCM, I'm sorry, not the SCM, your serratus muscles will actually help force you for exhalation. For forced internal inhalation to get really expand the rib cage, you'll get the SCM will be involved as well as the internal intercostals and a full contraction of the diaphragm to really open up the thoracic cage to allow the lungs to properly inflate. The diaphragm, again, innervated by the phrenic nerves. The external internal intercostals are going to be innervated by the thoracic nerves depending on where we are on the rib. So basically, the first intercostals will be innervated by T1. The rest of the intercostals between ribs T2 down to T12 are going to be innervated at the same level from T2 down to T12. Here's a nice inferior shot of the diaphragm. So basically you have the diaphragm will attach very simply from the central tendon all the way from the xiphoid process all around to the ribs, the coastal cartilage, all the way down through the posterior ribs 10, 11, and 12, and also attached into the lumbar vertebra L1 as well as the very lowest thoracic down to T12. So again, when we have full relaxation diaphragm, it balloons upwards superiorly. When it actually contracts, the central tendon pulls on all the muscle fibers and actually will help it pull it down inferiorly to help expand the rib cage. Those of you who have ever gotten the wind knocked out of you, if you've ever been hit, usually you see this in football, although you see it in other types of injuries too. I've had students that have been in bike accidents and they've hit the handlebars going over, whether it be a motorized bike or a motorcycle or whether it be a regular pedal bike. You get the wind knocked out of you. So what happens is you basically get a very quick paralyzation of the phrenic nerve, and the diaphragm just doesn't work. It's a very scary event. Thankfully, it's not something that's really serious. But basically, you're using your intercostals really to help you assist, inflate, and deflate the thoracic cage to allow you to breathe both in and out. Okay, so again, there's diaphragm. So it's going to originate that xiphoid process. Portion of the ribs, 7 to 12, the lumbar vertebra, also the intervertebral discs. It's going to insert into the central tendon. It's going to innervate through the phrenic nerve, and you have both the external and internal intercostals. So basically they attach from one rib above and below. External are going to run from inferior border to superior, and the internals will run across the other way from superior down to inferior. And again, they're all innervated by the corresponding thoracic spinal nerves. Okay, so for the pelvic viscera and the sphincters, so we're going to look at the female first. There's only a couple things I want you to be aware of. It's going to be the external sphincters. So we're going to look at the external anal sphincter, we'll look at the external urethral sphincter. Thankfully, the names of the muscles gives you an idea of what they actually do. So these are under voluntary control. So the external anal sphincter helps keep the orifice closed. The external urethral sphincter will actually help keep the urethra closed. Very important there. Compressor urethra also helps control urine flow. And the last thing I'm going to show you, at least on the female pelvic viscera, is going to be the pelvic floor muscles, the levator ani. You have the puborectalis, you have the pubococcygeus and ilococcygeus muscles. These all help maintain the pelvic floor and maintain strength for all the genital urinary organs. Usually if they tend to get weak, it can cause all kinds of ruptures and cause a lot of problems in the lower abdominal region. Most of the times if we see any kind of disruption with the pelvic floor, then a lot of times you'll have incontinence issues. You may have problems either holding back your urine or holding out problems with defecation. You may be prone or having some problems, especially when you cough or sneeze. If there's weakness in the pelvic floor in those three particular muscle groups, again, you can lose control of the bowels and or the urine. Now, the main difference I want to look at for the male pelvic viscera, we're going to add two muscles to this one here. So, of course, the male also has the external urethral sphincter, also has the external anal sphincter that does their respective jobs. You still have the levator ani that are made up with the puborectalis, the pubococcygeus, and the ilococcygeus muscles. They do the same work they do in the female viscera, except for the male, we're looking at two different muscle groups, which is going to be the ischiocavernosus and the bulbous spongiosus. These two muscles help maintain erection in the male. It does help with erection for the female with the clitoris, but it's more of a strong contraction you see in the male pelvic viscera. So again, it helps maintain the erection for sexual intercourse. So, next question. Father and son are on the bus heading to the supermarket when his son has to go to the bathroom. His father tells him he has to hold it until they get to the store. So what muscles have to stay contracted to prevent urination, and what opposing muscles are making that all the more difficult? So what you have to think about very simply is this. Which muscles are going to be under voluntary control? Which ones are going to be under involuntary control? So we're talking about urination. You're looking at the external urethral sphincter is trying to hold back. That's what your muscle you're using to kind of hold things back. And in partition, you're also using the compressor urethrae. You're also using it very little bit. You're also using your levator ani muscles, kind of hold everything back. Now, the question is, what muscle is working against you? So if think of it this way, if you have an external urethral sphincter, then you must have what kind of internal urethral sphincter? So if you have the internal urethral sphincter, this is under involuntary control. This is what you're fighting against all that particular time. And unfortunately, the internal urethral sphincter is going to win at some point in time. You have to go at some point. You may lose control, or you may fatigue the muscles in the pelvic floor, and you might wind up squirting some out a little bit. So that's one of the things I actually have to look for. We do see this a lot of times with lower back issues. We do see this a lot of times with very troublesome pregnancies, where a lot of times you're losing your control of the external, whether it be the urethral sphincter, whether it be the anal sphincter. And if we're talking about any kind of feces about to come forth, you're also fighting against the internal anal sphincter at the same time. That's constantly pushing onto the external anal sphincter, and eventually, again, you have to go at that point sometimes too. Okay. So far as levator ani, so very simple. I want you to know, for the most part, know the names of the muscles. Got the pubococcygeus, the puborectalis, and the ilococcygeus. These are all innervated by the sacrospinal nerves. So again, these help maintain position in the pelvic viscera. They help increase intra-abdominal pressure for forced exhalation, coughing, urination, defecation. Also constricts the anus, the urethra, and the vagina in the female. We talk about the male in particular for the ischiocavernosus. Also helps maintain intra-abdominal pressure. Will also pull the coccyx following defecation after birth or during childbirth. All these muscles help kind of maintain the pelvic floor. And these are all innervated by the sacrospinal nerves, S2 to S4. Now, there's only two muscles I really want you to pay attention to in the top chart here for the superficial perineal muscles. That's going to be the bulbous spongiosus and the ischiocavernosus. For the male in particular, it's called maintain erection of the spine. And what I want you to really understand is the perineal branch of the pudendal nerves, which controls those two muscles. So if you look, those of you who are Game of Thrones fans, if you look at the Unsullied, they're eunuchs basically. They have no use for these two different muscles anymore. They're useless. They really don't do very much of anything. And then once they're cut, then you lose all function for those different things. Now, as far as the deep perineal muscles, really I'm just really concerned mostly with the two sphincters. So the external urethral sphincter and the external anal sphincter. know what they hold back, and very simply know they're also going to be innervated by the pudendal nerves. The sphincters in particular will also be innervated by a portion of the rectal branch of the pudendal nerve in particular. Okay, so this is where it differentiates from the book. From the book and also from my original PowerPoint slides that we're going to use in the lecture, I would have skipped around, skipped ahead past all the upper extremities. It gets to the pectoral girdle, gets to the upper extremity, the proximal and distal portion of the limb. We're skipping all that and going into that for the appendicular in the second half of this video. So we're going to skip ahead to the muscles of the vertebral column. We're going to finish up with this in the next couple slides, and that'll be the end of everything that's going to be testable on the first quiz. Once you get through this particular video, you can start taking the quiz at that point, and then submit, and then once that's done, we can move on to the next video for the second quiz of this particular chapter. Okay, so muscles of the vertebral column. So you'll see some overlap here. So we're going to talk about some of the vertebra in the cervical area. We're going to see the same kind of muscles here. So we're going to look at the semispinalis capitis, which we talked about before, the splenius capitis muscles. Again, the majority of these muscles, if they're used bilaterally, will extend that particular portion of the spine. So if it crosses over the cervical, it will extend the cervical. Cross over the thoracic, it will extend thoracic, and so on and so forth down to the lumbar. If they're being used unilaterally, they will laterally flex and usually rotate to the same side. So again, if we look at the upper portion of the muscles here, if you look at the semispinalis capitis, you look at the spinalis capitis, which again, the spinalis capitis a lot of times is absent or is fused with the semispinalis capitis. That's pretty much the only thing I really need to know for the spinalis capitis muscle. Inferior to that is going to be the splenius capitis, a very strong muscle for helping extend the head. You also have the spinalis cervicis muscles, which are going to be found very deeply, very close to the actual spinous processes of the cervical spine. So you're going to see, if you go down through the thoracic area through here, you're going to see three bands of muscle. They're going to form what's called the erector spinae or the paraspinal musculature. So you're going to have three different bands. They're going to work from the lateral to medial. So what you're going to look at very simply is you're going to have the first set of muscles called the iliocostalis. So we're going to skip down to the pelvic area, down by the sacrum there. So the iliocostalis muscles are going to run from the lumbar, and they're going to terminate up by the first thoracic, first rib area. They're called iliocostalis because they cross over from the ilium, and they cross over where the ribs will articulate with the thoracic vertebra. So you have the iliocostalis lumborum, you have the iliocostalis thoracis. You also have the iliocostalis cervicis at the same time. So these will all originate in the lumbar area, thoracic area, also the cervicis or cervical area. Next layer in is going to be the longissimus muscles because they're very lengthy. So you're going to have the longissimus muscles are going to be found in the thoracic area. You can find longissimus muscles also found in the cervix area. The next areas closer in are going to be the spinalis muscles. You're going to find these spinalis thoracis. You can find these also the spinalis cervicis as well. So again, three different sets of muscles. You're going to have the iliocostalis being the most lateral. Next medial will be longissimus, and then next medial to that would be the spinalis muscles. So let's recap those one more time. So the iliocostalis muscle is going to be the most lateral. You're going to have a lumbar section, thoracic section, and a cervicis section. You move just medial to that, you're going to have the longissimus muscles. You're going to again have three partitions there, but going to be a slightly different orientation. You're going to have longissimus thoracis, you have longissimus cervicis, also have longissimus capitis. So in this case, instead of having a lumbar, you have one that's going to attach to the head. And then you go further in, you have the spinalis muscles. This will follow the same orientation as the longissimus. You have a thoracis, you're going to have a cervicis, and you're going to have a capitis muscle in certain portions of the population. Not everyone will have those. We'll go a little deeper and look at the small muscles in just a couple of seconds here. Now, if we go a little deeper, these are going to be the smallest muscles found in the spine. So you're basically going to have different muscles that are going to be interspersed in between the actual spinous processes, in this case, interspinalis muscles. And these very simply will help extend or hyperextend the individual vertebra upon each other. You have intertransversori. Good luck trying to spell those. Basically, these run from transverse process to transverse process. When these work singly, they will laterally flex to that side. Occasionally they will help or kind of aid in a little bit of hyperextension there at the same time. You'll have rotator muscles, which will run from the transverse process of the vertebra below to the spine's process of one above. The rotator muscles are going to help with rotation, so it kind of helps to give an idea of what kind of action that the muscles do, and they will pull to that particular side. Now, there's one muscle group that's not shown here called the multifidi. These will run pretty much up and down each level of the spine, very similar to the rotator muscles, except they will span sometimes 2, if not 3 vertebrae instead of just one adjacent above or below. But the multifidi also will aid in rotation to the same side. If they're using unilaterally, if they're bilaterally, they'll be contracting and help with extension. There's a very particular muscle group here called the scalene muscles. These are going to attach from the first and second rib and will attach into the cervical spine. These are very specialized muscles to aid with the inherent instability of the neck. So basically they're going to run from the upper cervicals, C1 and C2, and run down to the first and second rib. So if you notice here, there's 3 sets of scalene muscles. You have anterior, middle, and the posterior. The anterior scalenes are going to attach to the first rib, which is relatively thick and squat. It's going to attach to the upper cervicals. The middle scalene will also attach to the upper cervicals, in this case also up to the axis, and also attach to rib number 1. So these muscles are used individually. They're going to help flex the spine. When they work individually, they're going to rotate the spine to one side, help elevate the rib. If they use bilateral, they will flex the cervical spine. The posterior scalenes that you see here will attach to the lower cervicals and attach to rib number 2 instead of number 1. So here's a quick rundown of the origins and insertions of each of the sections of the paraspinal muscles. So if you go by the name of the muscle, that'll give you a clue as to where they're innervated from. So in this case, if you're talking about a cervix or a capitis muscle, they're going to be innervated by the cervicothoracic nerves. If you're talking about thoracic muscles, again, innervated by thoracic spinal nerves. The lumborum, of course, be the lumbar spinal nerves there as well. Okay, these are the smaller muscles. These are the transverse spinalis. These will not span over very many multiple vertebrae. A lot of times they'll just be between 2 vertebrae. The one oddball will be the multifidi. These will actually cross over 2, if not 3 vertebrae, but they'll be far shorter than some of the paraspinal muscles you just saw a couple slides back. So again, these are primarily going to be innervated by either cervical, thoracic, or the lumbar spinal nerves, depending on what level that we find them at. Okay, and there's the longitudinal muscles, again, also innervated by the appropriate spinal nerves. Okay, the scalene muscles in particular. So the scalene muscles will help rotate the neck, also will help rotate the cervical spine, and in some cases will also help elevate the first and second rib. These are also innervated by the cervical spinal nerves. All right, and this should be the last slide. So this should end everything for part 1. This will take care of, I believe, quiz number 5, I believe. I'll double check that for you. But very simply, all the slides we just talked about, all the innovations, all the actions are going to be fair game for the quiz, and definitely fair game for the next exam, which will cover chapters 10, 11, and 12. You've already gone through the muscle tissue. You've gone halfway through the muscular system. The next portion will be the appendicular, and we'll finish up with nervous tissue thereafter. But unfortunately, guys, ladies and gentlemen, this is one of those chapters where you just got to study, you got to memorize. This is where Wiley Plus really comes in handy. There's a lot of animations and activities to really kind of plug things together, which I'll link in a couple of descriptions. Some may actually be some assignments for you there as well. It's just really trying to hammer home all different muscles, what they do, how they interact with each other, and how they're innervated too. But I'll try and post as many of the animations as I can.